CrisisCrisis, and we've sort of started referring to this topic with this phrase, a little bit getting into this notion of what is a crisis really in schools, and recognizing that this term crisis at times is being overutilized. We want to be careful when we talk about this topic to recognize true crisis and when there are real crises in schools, and we never want to minimize the importance of when a youth or an adult in a school is in a crisis and the importance of addressing that in an appropriate way. There's this sort of epidemic that's happening, though, where a lot of instances or circumstances in schools that may not be a true crisis are taking over a lot of the time of clinicians and administrators and others in the building. So we are going to dig a little bit deeper into this topic, try to keep it a bit brief today, but make sure that we're all hearing the same key messages as we move forward talking about this. So when you think about the cycle of what can happen in schools with a crisis, you may see a variation of something like this. You get a student who displays a behavior in the classroom or in a more unstructured setting, but oftentimes in a classroom, and you have a teacher who then responds to that behavior in some way. We have a whole continuum of responses that we talk about with teachers, but there's some way that a teacher ends up responding to a student. And then oftentimes a student will end up responding back to that teacher. So sometimes that ends up being in an appropriate way, and quite often it's in an inappropriate manner. So then the teacher sometimes, if this really escalates, the teacher may end up contacting a clinician or even contacting an administrator. And at that point, you have a third party who comes in to try to respond to the student and address the student. And this cycle often happens in schools, and we see it, all the time. If you've lived in schools, you see this kind of a thing happen all the time. So we want to talk for a few minutes about what happens when a clinician comes and responds to a student in this type of setting. And when we say clinician, we're talking about social worker, psychologist, counselor, these types of roles in the building. So when a clinician comes into a classroom and addresses a student, there's actually function of the student's behavior that's being met in that type of circumstance. Most often in schools, you have a student who is trying to avoid work or trying to gain adult attention, and when an adult comes in then to address the student, either and both of those functions may be met in that kind of an instance. So there's definitely a need being met by the student when a clinician comes in to address their behavior. There's also a need that's being met by the teacher. So whether that is a feeling of wanting a student to be out of the classroom so that they can address the needs of the rest of the students, whether it is a lack of a skill set for that teacher, maybe. Sometimes we have teachers who just don't have the skills to be able to address certain behaviors in the classroom. A lot of times that's not taught in schools to teachers. So whatever the case may be for the teacher, there's some need that's being met for them when somebody else comes in to be able to address the problem behavior. And the last part, which is often tough to talk about with groups of clinicians, but is so important to, and having been a social worker in schools myself, I'm definitely willing to be reflective and address this issue that there's a need being met of the clinicians as well. So sometimes it's sort of this hero effect where we feel like we're coming and swooping in and saving the day, but there's something for a clinician that's being met in the circumstance as well, feeling like we're helping, feeling like we're helping save the moment. So the challenge is when you have a student's need being met and a teacher's need being met and a clinician's need being met, there's a high likelihood of everyone being comfortable enough with this cycle that they're not looking to disrupt it and try to make a strong change. And so we have this cycle happening over and over in schools, and unfortunately it has quite a negative impact on our clinicians and our administrators whose time is just being eaten up with these kinds of circumstances. So what this can lead to is something that we've been calling the walkie-talkie epidemic. It's kind of just meant to, whether you have walkie-talkies in your building or not, it's just meant to represent this notion of some kind of a vehicle that allows us to access the clinician at any point in time. And the notion would be that a clinician would drop everything and go to the person who is saying, I need assistance at this moment. And we don't always think about all the different ways that students and parents and others can be impacted when we do this. So there's such an urgency that happens with this call to come and address something that oftentimes clinicians are already sitting with some student who maybe has high-level needs as it is, or another teacher or somebody who's in need, and we sort of put those needs aside and go and address this other issue that someone has decided is urgent enough to call us on a walkie-talkie or a phone or something that says we need to be there immediately. And when you get into this sort of a mode, then anything truly can be considered a crisis. So it's left up to the person in the circumstance to decide whether they think it's a crisis or not, and that's often quite subjective in those moments. And so what ends up happening is that clinicians end up being these sort of fairy godmothers and fairy godfathers, where we're almost expected to just fly in at any time and say, you know, we're going to make things all better. And while we all may wish that we have magic wands, that's not the case. And some people have also referred to it as being a firefighter and coming in at any time to put out the fires. So this can be really challenging when you're in a school with hundreds of kids and hundreds of, you know, whether it's 50 or 100 or 500 or 2,000. There's so many more kids who need support than one person would possibly be able to address. So the notion that the shift that we're looking for and the place that we want people's minds to be moving or evolving to is not just having clinicians be the response to social emotional needs or behavioral needs, but transforming into leaders who are able to support the rest of the staff to build their capacity to support students in a more, in a wider way, and get a further reach at Tier 1. So if we can be giving more skills to teachers down at Tier 1 and to other staff members, we're going to help build the capacity of the whole staff and free up some of the time for the clinicians to be able to do more work with kids with higher level needs and others throughout the building. So we asked the question for clinicians to get reflective on how they're currently spending their time. So these triangles represent time spent. So we can use triangles in a lot of different ways. In this case, we're using it to talk about time spent. So the triangle on the left would show a model where a clinician is spending quite a bit of time addressing Tier 1 level needs, a little bit of time at Tier 2, and very little time up at Tier 3 with the highest level needs in the building. On the right, we have the flip of that. So a clinician would be spending the majority of the time working with students with Tier 3 needs, and then some time with Tier 2 and less time with Tier 1 needs. So the question we ask is for folks to get reflective on how are you currently spending your time? Which of these triangles would you say represents the current time being spent? And then we challenge people to think about which is the one that you would want. And what we often hear is that the one on the left is how clinicians are currently functioning. They're spending a lot of time with needs and issues that are more where the needs are better met with Tier 1 supports. And we can consider a clinician being a very high-level support. Clinicians are of the most intense supports that we have to offer in a building, meaning after a clinician, there's often not a whole lot else that we would turn to help support a student in an intense way. So if you're utilizing the highest level of resources that we have with the lowest level of needs, there's really a miss, and we're not going to be able to be the most effective and efficient with our resources if we do it that way. So if you look at the model on the right, we would be freeing up time for clinicians to spend the bulk of their time with the highest level needs, and you have a really nice match then with high level needs of students being met with high level resources that we have available. So different clinicians have told us different things about which model they're in and which model they desire. But in terms of being able to most effectively support all kids in a building with a systematized model that not only addresses individuals but is also addressing all of our youth and staff in a more systematized way, the model on the right is going to free up clinicians to be able to match the needs of the highest level needs in the building. So as this role that we're in continues to evolve, and I would say it's an evolving role over time, we continue to think about, learn about, grow from the work that we're doing. There's a couple major systems that we would point out that we'd want to be thinking about. I'm going to point out a few here, and then I'm going to go quickly deeper into one or two of them, and we'll keep moving. So communication is going to be critical, having consistency and understanding the role of what the clinician does. Oftentimes, if you ask folks in schools what it is that a clinician does, you can get a mixed answer, mixed reviews on what it is that we do. And it's going to be important that there's really strong communication about what it is we do and then some systems around that. Systemic delivery of professional development. We're moving into this mode where clinicians are becoming leaders. We call them social emotional leaders of this work. And that means we're counting on clinicians to help with professional development of the rest of the staff to build their capacity to support needs at Tier 1 and needs throughout the school. So that means we need to do professional development with our staff, and it sure makes a lot of sense that clinicians would be able to help support that work. For some clinicians, that's a really comfortable seat to sit in as a leader and a teacher of other staff members. And for some clinicians, that's a pretty uncomfortable position to be in. And sometimes they'll say that's not what I signed up for, kind of a response. So we're working to have folks embrace this notion as the role evolves about being a leader and helping to deliver some professional development to the rest of the staff. Definitely a coaching framework being in place so that clinicians themselves can receive ongoing feedback. Getting support live time is really important, and in schools we're kind of, there's almost like a fear right now of people coming to watch the work that you're doing, whether you're a teacher and another teacher comes in to observe, or whether you're a clinician and another clinician comes in to observe, or somebody in a different role. There's a fear of that, I think, because of all the evaluation that goes on in schools. But we want to create an environment where it's okay to get coached, and we want clinicians to invite other clinicians in to observe and coach them. And we also really want this environment, I think, where clinicians are able to go into other settings and be coaches as well. So having a coaching culture, I would say, is going to be a really important thing. Reevaluating teaming and evolving in our thoughts about how we team is going to be really important as we move forward as well. So how we utilize grade level team meetings and problem solving team meetings. Traditionally, we see that team meetings, problem solving team meetings are taken up with what we call kid talk. So we're coming with lists of kids and we're talking about individual youth instead of maybe taking that time to do professional development and build the capacity of the staff. So if you think about a teaming time where a group is talking about, let's say, Johnny, and figuring out strategies and how they can help support Johnny and what they've done that has worked or not worked, if you shift that conversation and it moves towards talking about some strategies that teachers could use for all students who might present with that problem behavior, you're really going to build out the capacity of the staff to help support all the Johnnies in the future. So we're looking at trying to, like with everything else, make things more effective and efficient to be able to help support all of our youth. And we're going to be looking at screening and how youth get access to clinician support. So often this mentality, which we were just speaking about, where anybody can kind of get the clinician support at any point in time in schools, we want to be moving towards a systematized approach to how folks in the building access the clinician, and whether that's parents accessing clinician support for their kids, students accessing clinician support themselves, or teachers looking for some help and support from a clinician. We want to get that a little bit more systematized and streamlined so that we're not overutilizing that support, and so that it's not subjective and the squeaky wheel gets the oil, so to speak. So it can be pretty dangerous with disproportionality concerns, things like that, when we use subjective measures to get kids support. So it's important to figure out, how do we define a crisis? And if you start to think about what if we all defined it in the exact same way, that would allow us to get a little bit more effective, efficient, and use data, maybe even to make some decisions, which is a crazy thought, right? So what if we defined it in the same way, and what if we were able to provide some replacement behaviors to our adults? So if you think about that cycle, and if there's an adult need being met by a clinician coming in to support them, if we gave some replacement behaviors to the staff and some other tools in their toolbox for how to address some of these problem behaviors, they may be less likely to make those calls as often. So those are some of the things that we'll be thinking about as we move forward. So these are some of the major points that we've talked about the last time that we had a clinician learning forum last year. And as we talk about this topic, these are some of the main points. And we've had a couple of schools start to move forward with exploring some of these points that we've talked about. And we're really looking forward to some more folks doing that as we move forward. So we wanted to take a quick look at some examples. Out of Crystal Lake, District 47, they had some great work that they started to do. As we started to talk about defining a crisis, we mentioned the notion of T-charts, and that lots of schools, especially schools that are doing PBIS or MTSS for behavior kind of work, they may have a T-chart already established where we are defining behaviors that are meant to be handled in the classroom, behaviors that are meant to be handled in the office, with the hope of getting more streamlined and systematized with how we address student behavior. So in this example, these folks divided a T-chart into what should be handled in the classroom and then what should be going to a clinician. And so if you look on the left, you're pretty much going to see behaviors that they then took a look at function and sort of used the function approach to talk about the behaviors. So behaviors to gain or avoid attention, to avoid work. So they took sort of the function approach to describing the behaviors. And then on the right, they talked about what many of us would consider true crisis moments where a student or an adult is talking about hurting themselves or hurting someone else, or disclosing about abuse or threats of some kind. So those may be things that, those would be things that we would consider important to be able to send to a clinician, and hopefully we would have schools agreeing with that. So this is just an example of what a T-chart could look like. Here's an example from Middle Fork, which is their response to what a T-chart could look like. And for this one, they took the typical T-chart, which we talk about, and added that third column, which is another example that we have given. So you see here, it's very small, we'll blow it up a bit, but on the left is classroom, staff managed in the classroom by teachers. The middle column is administrative managed, or things that would go to the office, and then the third column is something that might be sent to a clinician, or they even mentioned to a nurse, which is pretty neat. So you start to divide it out and get some consistency amongst your staff for what things they would send where. So this is this was a blown up version of a couple of lines from the Middle Fork example, and here's one line, and then I have one on the next slide as well. So if you look here for classroom managed, and then administrator managed, and then social worker or nurse managed. So we have non-compliance and defiance, like a student refusing to follow directions or refusing to complete academic work, and that is something that would be handled in the classroom. For administration, to handle something like physical aggression, so a student who engages in deliberate actions involving serious physical contact or injury, or injury can occur. And then to a clinician would go a concern like student has expressed that they plan to hurt themselves or others. So by dividing this up into a T-chart with these three columns, you make it really clear to your staff what exactly should be done, what we should be doing for these circumstances and who exactly should be handling them. And I think it's important to at least mention that if you're going to have a document like this, which Middle Fork created, which is really great, you're going to want to make sure you spend a little bit of time doing PD with your staff on how exactly to utilize this kind of document. Here's just another quick example from that Middle Fork document, which looks at inappropriate behavior that we would want to be addressing for these different areas again. So in the classroom, we've got student walks out of the classroom unaccompanied or is in an area other than the designated one, and this is a location issue where a kid's supposed to be. The second one, which would go to an administrator, would be repeated verbal, written, or gestural messages to another that attempt to intimidate or threaten. And that, I think threatening harm kind of goes on the fence of folks having to decide if it's in the moment concern that it's about to happen the second, or whether it would be addressed in a different manner. So some of those things would have to be, you'd have to dig into it deeper with your staff. And then for a social worker or a nurse, if a student leaves the building, is unaccompanied, or is missing. So this is just an example of how one school started to move towards some criteria, some defining categories, and starting to get clarity for their staff. So we threw together an example template here of what you or others could use to start to define what you want your teachers to be sending to the front office, to a clinician's office, or handling themselves in the classroom. And the trick is, if you say to a staff member, you need to be handling this thing in the classroom, then we better follow that up with some professional development on how exactly to do that and what tools they can be using. So that shifts us right into this notion of professional development, and we ask this question, what if all teachers had a better understanding of some of these areas of content here so that they would be able to handle more within the classroom and maybe develop some skills to address more behavior. So if you think about classroom practices, or the notion of classroom management, if you think about function and behavior, restorative practices, trauma, these are some of the big topics that we talk about with clinicians and others, that if we could develop some PD here and be able to have our social emotional leaders in the building, our clinicians and our administrators, delivering some of this content, developing the skill sets of their staff, what would happen in our classrooms? And I think the answer is that our teachers would have to send things that they're considering to be crisis to the clinicians less often. I think that's our hope. So in terms of doing some professional development and trying to give replacement behaviors to staff, here's an example back again from the Crystal Lake School District. They broke down into a few different categories here, some skill sets that they'd be teaching to their teachers and have their teachers be using as responses in the classrooms. So the idea here is that we would put a little bit of a stopgap. Before a teacher sent a student directly to a clinician for an issue, they would be deciding how intense of a concern that problem behavior is at that time. And we the notion came up to throw out these categories of green, yellow, and red. So less intense is green, more intense is red. But the idea here is that if you break down the student behaviors in terms of a green behavior is not as intense, yellow getting there, and then red is a highly intense behavior, what strategies would we want teachers to be utilizing in the classroom? So this is just an example of how to break down some things that teachers can be using and doing in the classroom based on the level of intensity of the behavior that they're seeing. And this is going to allow teachers to do more in the classroom before they would send kids to the clinician. And this is an example then of student responses. So could we be teaching students some skill sets themselves for ways that they can manage their own emotions and do some regulation and address some issues themselves before it necessarily had to go to a clinician? So this is just them breaking down what are some strategies that they can be given to kids if it's a green concern, if it's a yellow concern, and if it's a red concern. We already gave the teaming example earlier, so I'm not going to repeat this one again, but it's the notion of starting to deliver professional development to our staff during problem-solving team meetings instead of spending the bulk of the time focusing on individual kids. And I always say if you're concerned enough about a kid that their name is on a list somewhere at some meeting in your building, then they probably should already have started into early Tier 2. In Tier 2, we're trying to catch kids before there's a major concern, so if their name is already coming up at a team meeting, you probably have enough concern that they should be put into early Tier 2. So if we utilize that time for professional development instead, we may get better and more outcomes. Plus, people are constantly asking with all this professional development, when do you expect us to do it? And that's my number one time to give schools that I recommend is during the time where you'd be talking about individual kids, let's replace that with some professional development. This is just an example, again, of some of the classroom strategies that we can be giving to teachers to be able to help support the kids in their classroom. And if clinicians start to get fearful of, you know, how can I teach a strategy to a teacher because I'm not a teacher and I don't live in the classroom like that, clinicians are experts with behavior, so there's absolutely a place for them teaching behavior to other teachers. So it's actually a really great fit. So that's the bulk of the content we have here around some really important messages with the crisis that we have going on in schools and how to start to streamline the way that we're talking about crisis and teach some more skills to teachers and teach some more skills to kids so that we have some options of what to do before a concern would go straight to a clinician if it's not an actual threat of harm to self or others. So there's been some action steps that folks have done since the last time that we did a learning forum for clinicians and administrators. And here's a few things that people have done since then. So folks have gone and updated their T-chart to include that third column of what goes to the clinician. So they've got their what's handled in the classroom, the front office, and then the clinician's office. We've gotten folks who are tightening up their systems for what they do when a student is in a crisis situation. So these folks said they took to heart the cycle and they were reinforcing that cycle, which so many of us do, by always running to it right away. So they put in some new procedures for responding to those crises, which is great. And having a clear understanding of the roles. So we want to get the roles clearly defined, which we'll talk about in another module, so that everyone has a clear understanding of what exactly it is that the clinician does. In addition, we have had more collaboration, so less crisis, building teachers' capacity for social emotional interventions within the classroom and more collaborating in the process. So less admiring of the problem and less looking to clinicians to just come in and quote unquote solve it. A clearer view of when to refer to clinicians versus the dean or the administrators, creating that three-tiered chart which outlines caseload within all three settings. So we're getting a lot more clarity around these different pieces. Defining processes, monthly PD for all staff. So we got a lot of great feedback of what people have done since the last time we really got together to talk about this work. So some next steps for clinicians and partnering with their administrators. We know that partnership is so important if we're going to build the capacity of the staff to help support this work. So a few things you can do right away to start to think about this in real time in your own buildings. Make sure that all key stakeholders can describe the role of the clinician in the same way. So if you ask an administrator what the clinician does, if you ask clinicians what it is you do, and if you ask staff what is it that your clinicians do in the building, could they all define that role in the exact same way? And we would hope that they could. So maybe we can work towards that and work with your teams on some definitions. Establishing criteria for what goes to the clinician's office. So getting more systematized and clear on how we're doing that, we want it to be more objective than subjective. We're always trying to use data to make these decisions the best that we can. Of course, knowing that there's exceptions to that. Tracking data on time spent handling crisis. So when you actually dig into the data and you ask clinicians how they're spending their time, and not in an evaluative way, but asking them just to get reflective, it's really interesting to see how much time is being spent on crisis. It's quite a bit. It can be staggering, some of those numbers that come out. So maybe that's something to do, is to go and actually start digging into the data. Together, admin and clinicians create a PD plan for skills to teach youth and teachers to prevent the need for this continuous notion of urgent response. And so could you get together and start to talk about what PD topics might make sense for your building and what skills to deliver to your staff? And things that can help you get started right away that you can do as soon as possible would be to get a sense of your own time and how much time is spent responding to crisis. When I was a social worker in schools, I wanted to sort of take the bull by the horns and figure out by myself how my time was being spent, not during a time study that somebody else was asking me to do, but I really wanted to own that and get reflective on how my time was being spent, and then use that data to talk with key stakeholders about some shifts that we could make. So it can be really empowering for you to sit down yourself and look at how your own time is being spent. Identify some key allies in your school to help you be aware of how time is spent and the need to change your thinking about crisis. So who's going to give you that permission to say no? I think that's something that's at least how I think of it, and some important terminology there, that it's going to be okay to say, no, this needs to be handled by somebody else. So who's your partner in crime that's allowing you to give that permission? Hopefully it's at least an administrator, but then also maybe you have some colleagues around you who are going to be your accountability buddies in your self-care process to protect yourself and protect your role so that you can help the kids who need it the most. And that's it. That's where we got to. We're just about at 33 minutes. So